So this is a talk that I've given several years ago, and it probably needs to be updated a little bit, but it really kind of consolidates the big three diseases that we treat with anti-VEGF therapy. So this is an update on macular diseases. And the macular diseases we're going to be talking about are going to be age-related macular degeneration, diabetic macular edema, and retinal vein occlusion. Because I made this several years ago, some of these disclosures are not up to date, but suffice to say I have multiple disclosures, none of which should really affect this talk that I'm doing. So what we're really going to do is we're going to look at the background of common macular problems, focusing on wet age-related macular degeneration, a little bit of dry macular degeneration, retinal vein occlusion, and diabetic macular edema, how we diagnose these things, and what our current and future treatments hold. Once again, some of this may be a little bit old data, and I'll try to imply that wherever I see that is, in fact, the case. So let's talk first about age-related macular degeneration. We know that it's the leading cause of blindness in the United States, taking over about 50% of cases of blindness in the U.S. And when we look at the United States, 8 million people have some form of macular degeneration. That's either dry or wet. 1.75 million people have the wet form of age-related macular degeneration, and this number is just increasing as time goes by, with 200,000 new cases of wet AMD annually, and that's probably a bit of an underestimate. And it's estimated that this number is going to grow, and by now we should be surpassing the 3 million mark. Once again, this talk's about 4 years old. We're going to see a significant increase, almost a doubling of age-related macular degeneration by 2050. And this is not just a problem in the U.S., it's a problem worldwide. When we look at it, it's particularly impactful because it's such a bilateral disease. So if you have wet AMD in one eye, you have a 15% chance of having wet AMD in your fellow eye within the next 5 years. If you have wet AMD and large drusen or aging changes in the back of the eye, that 5-year risk goes up to 35%. If you have wet AMD in one eye and large drusen along with RP hyperplasia in your fellow eye, over a 50% chance. And we know both wet and dry age-related macular degeneration increases with age. So let's take a look at both wet and dry macular degeneration, starting first with dry AMD. Dry AMD is really the development of these abnormal deposits underneath the retina called drusen. They're typically yellowish, and we can see them on the image here. They usually will lie between Bruch's membrane and the RPE, and they tend not to cause significant vision loss. We do use ARADS vitamins, and we'll talk a bit about that. So the real key for dry age-related macular degeneration, at least at this point, is earlier diagnosis. This is an older image of a device called the 4C Home device that works on preferential hyperacuity perimetry. And this basically involves showing subjects a series of lines that has a bend in them very rapidly, and the patient tries to identify the bend on a kind of a digital image. And if they have new wet macular degeneration, they will identify the wrong bent line or the wrong area of bend in the line. And studies have shown that patients that use this device at home, and imagine it's difficult, it's a technologically kind of intricate device. Patients who use this device and can use this device can be found to have wet macular degeneration over 90% of the time while they're still 20/40. So it's very good at early diagnosis. What about any therapies to prevent or reduce the progression to wet macular degeneration? Well, there was a big study of about 4,000 plus patients several years ago. We were part of this study. It's called the ARAD study, or Age-Related Eye Disease Study. And what they looked at is a combination of antioxidants or antioxidants and zinc versus zinc alone. And they actually showed that the antioxidants plus zinc showed a significant reduction in development of age-related macular degeneration or progression of age-related macular degeneration. But it really only worked for patients who had at least one intermediate or large-sized drusen. So the patient in Picture B, believe it or not, would actually qualify for the ARADS vitamins. But really who we're looking at is the patient in Picture C, large soft drusen and some RP hyperplasia. What ARADS vitamins did not do in either the first or the second study is reduce the progression of geographic atrophy. And we'll talk a little bit about geographic atrophy later. This is a hot area of interest as far as developing therapeutics for the inhibition of complement and other factors to try and stop the progression of this condition. The ARADS 2 study, which was PI'd by Dr. Rick Eisenhagen here in our group, actually was very similar to the original ARAD study, with the exception of they removed beta-carotene and supplemented it with lutein and zeaxanthine. There was some thought that beta-carotene may increase the risk of lung cancer in patients who have smoked or were active smokers, and lutein and zeaxanthine did not do that. And they looked also at fish oil and the combination of these two things. And the conclusions really were that the original ARADS was pretty good because the ARADS 2 formulation really didn't do anything better as far as reducing the progression to advanced AMD, that lutein and zeaxanthine could easily be substituted for beta-carotene, that fish oil or omega-3 fatty acids were not effective. Lower levels of zinc, they try to lower zinc concentration, no benefit. No benefit for geographic atrophy, and it was most effective in the nutritionally poor patients. There's been a variety of different studies looking at genetic biomarkers and the impact of vitamins, and really suffice to say that there's been no significant findings that point towards anything that could really help us. This is a genetic study that we actually did looking at VEGF receptor polymorphisms, as well as the ARMS2 and complement factor H polymorphisms, as far as visual acuity outcomes and number of injections needed. Future therapies are going to be looking at trying to inhibit geographic atrophy. This was results from a phase 2 study that Genentech had looking at anti-factor D called lampalizumab, and unfortunately it failed in its phase 3 study. Let's talk a little bit about wet age-related macular degeneration. So we're really talking about, we're going to talk about the anti-VEGF area, treatment strategies, cost versus efficacy versus safety, and then what about some newer therapies? So when we look at VEGF and anti-VEGF therapy, we're going to see that there's a long and rich history of anti-VEGF therapy. Anti-VEGF binds, or VEGF binds to receptors and activates intracellular pathways that lead to proliferation of abnormal blood vessels and permeability of abnormal blood vessels. And the goal really of our therapeutics for the most part at this point has been to block vascular endothelial growth factor. And what we can see is that they are effective. And studies have shown that the chances of blindness from wet macular degeneration have gone down significantly across the board. And we see this actually in my lifetime. When I started, the old dogma is that when you're talking about severe vision loss, 90% of macular degeneration was caused by dry macular degeneration and 10% by wet. But if you're talking about blindness, 90% of blindness was from wet and 10% was from dry. Fast forward to the anti-VEGF era, and now we're seeing that wet macular degeneration causes less cases of blindness than it did in the past, and dry macular degeneration is causing more. And that's not because we see more atrophy. It's simply because we're doing a much better job of cutting down on vision loss from wet age-related macular degeneration. So let's talk about some historic therapies. These are important to really understand and know where we've come from. So really prior to 2000 or 1999, the only therapy we had was thermal laser treatment. And unfortunately, thermal laser treatment caused significant vision loss if you did it in the foveal area. And if you did it in a juxtafoveal location, these patients would oftentimes have a scotoma that would be very bothersome. Extrafoveal or outside of the foveal area, you could get away with it. But really in 1999, we had the approval of verteporfin, or PDT, where we injected a medication into the arm, it circulated up into the eye, and we've shown a specific wavelength laser light into the eye to activate the medication inside the abnormal blood vessels. And in those patients who had predominantly classic lesions, those are very leaky lesions, which is only about 15 to 20% of patients, it actually reduced the progression of vision loss. So we could see here a downward slope to the line. So patients still lost vision, but they lost vision less rapidly than if we did nothing. A few years later, in 2004, we had the approval of Macugen. And Macugen was really the first anti-VEGF therapy. And unfortunately, it only bound one isoform of VEGF, VEGF 165. And there were multiple different isoforms and subtypes of VEGF. And although it also slowed the rate of vision loss, patients still lost vision receiving injections every 6 weeks. So it was more effective, and it worked across all subtypes of choroidal neovascularization. But it wasn't a panacea. It didn't improve vision. Fast forward to 2004, and that was when Avastin was first utilized in the eye at Bascom Palmer, and Lucentis or ranibizumab was under development. We finally started to see therapies that actually could improve vision. So let's talk a little bit about our 3 most commonly used therapies now. The first is Avastin or bevacizumab. It's a full-length antibody. It was developed by Genentech. It is FDA approved for the use of cancer treatment, but not FDA approved for use in the eye. We use it off-label, and it is the most commonly used anti-VEGF therapy in the eye in the United States and worldwide, and you do have to have it compounded, and there might be some issues with that, as we can see historically. The first injections and first paper were written by Phil Rosenfeld, Andrew Moshfeghi, and Carmen Puliafito, where they used it for patients with wet macular degeneration. And we saw this amazing result. Patients' leakage decreased. Oftentimes their visual acuity improved, and this was a very, very exciting therapy. And we can see here it is the most commonly used anti-VEGF therapy in the eye. And the reason is because it's affordable. Currently, insurances tend to prefer this, and so we tend to have to use it as a first-line therapy. There are a few potential downsides. It's not quite as strong. It doesn't quite last as long as some of our other anti-VEGF therapies, but it's still a very affordable alternative. When we look at a study done comparing ranibizumab or Lucentis to Avastin, it's called the CAT study, stands for Comparison of Age-Related Macular Degeneration Treatment Trials. We had 40-plus centers across the United States. We were one of these. Tom Stone was our PI. And the CAT study compared Avastin to Lucentis, and it compared 2 different treatment groups. It compared monthly treatment to as needed, or what we call PRN retreatment. So you were either randomized to get monthly or as needed, and you were randomized to get either Lucentis or Avastin in those 2 groups. And we can see that there really wasn't much difference across the board between these groups. We saw that the Avastin monthly and the Lucentis monthly both did equally well. The Lucentis monthly did about a letter better than the Lucentis as needed did about a letter better than the Avastin monthly or as needed group. But once again, all these patients did rather well. We can see the OCTs show that there was a difference in a drying effect. And the monthly Lucentis patients actually had drier maculas across the board. We can see that the patients who had percentage of patients with no fluid at the end of year 1 was greatest in the Lucentis monthly group, followed by Avastin monthly, which was very close to the Lucentis as needed. However, we also saw some increase in geographic atrophy. Now, the thought is that this might just be because we have a drier retina. We can actually see atrophy of the retinal pigment epithelium much, much better than we have when you have some leakage present. One of the downsides to using Avastin, as mentioned earlier, is the potential for this compounding pharmacy error, and we can see that that's happened in multiple different areas across the world, and it can be, frankly speaking, quite significant if you have it happen to you. We obtain our Avastin from 2 different compounding pharmacies just to try and avoid any potential for compounding errors. The first FDA-approved pan-VEGF blocking antibody fragment was Lucentis or ranibizumab. It was approved in 2006. As of right now, over 10,000 patients have been involved in the clinical trials. We did have a study called the Harbor study looking at a higher dose of Lucentis, a 2 milligram dose compared to a 0.5 milligram dose for age-related macular degeneration, and we really didn't see that the higher dose worked any more effectively. You can see here the dates and the studies that led to the approval of Lucentis for AMD in 2006, RVO in 2010, and DME in 2012. What's very interesting is that Avastin and Lucentis are really cousins. So if we look at a mouse anti-VEGF monoclonal antibody, what Genentech did was they humanized it, and that made it the Avastin or bevacizumab antibody. They took a fragment, one of the small arms that's the binding arm, the top part of the Y, and they segmented that all out and created just a small antibody fragment called RuFab, and that was the name of the antibody fragment through the phase 2 and into the phase 3 studies. They then did this process of affinity maturation where they changed like 6 or 7 amino acids to make it bind VEGF much more tightly, and that's how we got Lucentis. So Lucentis is a much smaller antibody fragment, whereas Avastin is about 150 kilodaltons. Lucentis is about a third the size. It binds all VEGF isoforms. Most of the approvals are on monthly dosing. And we can see the half-life and vitreous concentration here to show that it actually does last a little bit longer than a month. The clinical studies that led to the approval of Lucentis for macular degeneration were the Marina and Anchor studies. And it was really interesting because prior to this, we classified choroidal neovascularization as being minimally classic or occult or predominantly classic. Because anti-VEGF therapies work across the board for all of these different subtypes of lesions, we no longer classify wet AMD as minimally classic / occult or predominantly classic. Now we lump them all together as wet AMD. But back then, because there were differences in PDT outcomes between the minimally classic and the predominantly classic, they studied them each separately. So the Marina was for the minimally classic and occult, and the Anchor was for the predominantly classic. And what we could see is for both treatments, the Lucentis did outstanding. And in the Marina study, looking at the occult lesions, gained about 1.5 lines of vision, whereas the control group was sham, no treatment whatsoever. And then in the predominantly classic Anchor study, you could see over 2 lines or 10.7 letters gained compared to PDT, actually, where we lost 2 lines of vision. So in general, over 20 letters of difference versus the standard of care. And this is an absolutely outstanding result. We can see that there were a significant number of patients gaining 15 letters or 3 lines of vision. And we speak oftentimes now in the anti-VEGF era as gaining 3 lines or 15 letters of vision as being one of our kind of gold standards that we look at. And we can see 33 to 41% of patients gain 3 or more lines of vision. In fact, 6 lines of vision, 6% and 14%. 6 lines of visual acuity gains are absolutely exceptional. The third treatment that we use is Eylea or aflibercept. This is a fusion antibody. It was produced by Regeneron. It was FDA approved in 2011. It's approved for AMD, CRVO, and now DME and BRVO. It was formerly known as VEGF trap. And what they did was Regeneron actually took the VEGF receptors that we find on the cells, and they found a way to uniquely isolate those, and they blended them and created this Frankenstein antibody that basically has VEGF receptor 1 and VEGF receptor 2 on each of those active arms of the full-length antibody. And so the VEGF thinks this is its home, and so therefore it will bind much more tightly to this than it does to other treatments. So once again, it's a larger antibody. It binds all isoforms of VEGF as well as placental growth factor. And we don't know the role of placental growth factor in many of these ocular diseases other than to say it's upregulated in some conditions like CRVO, BRVO, and diabetic macular edema. We do now know the vitreous half-life a little bit better. I think it's about 9 days, but the concentration's high enough that we see effective concentrations out to 70 days. It can be monthly or 8-week dosing, and this is based on the View 1 and View 2 studies where they actually looked at monthly dosing versus every other month dosing, and it was compared to ranibizumab monthly. And we've had patients that we've treated with this that have been less than responsive to other therapies and have actually responded to this. And we don't know if it's the increased molarity, the higher binding affinity, or the effect on placental growth factor, or some other issue that allows it to dry these patients more effectively. You know, a variety of different questions. Is Avastin as safe and effective? I think we can say from the CAT study and the DRCR protocol T study that is probably not quite as effective as the other two agents. Is Lucentis safer systemically? It's got a shorter half-life. It's a smaller antibody fragment. There's some thought to that, although there's a question about whether there's a systemic safety issue at all with these VEGF inhibitors. And is Eylea better for pigment epithelial detachments? And then the big question is which is better overall? You know, we mentioned the safety. I feel as though we haven't had as many compounding issues, although they might just be not spoken about. But we know initially we've had several cases of outbreaks of endophthalmitis from contaminated bottles of Avastin at compounding pharmacies. We have had some suggestion that maybe there's some significant difference in safety, but nothing at all conclusive between ranibizumab and bevacizumab in the CAT study. I think it's safe to say that it's probably safe systemically, although we all have cases like this. This is an 86-year-old gentleman who's coming in and he's getting injections fairly frequently, and he did not return for his appointment because he had an MI. So we know from oncology studies that intravenous anti-VEGF therapy, given at 200 to 300 times the dose we're giving it in the eye and given it IV every 2 weeks versus every 4, 6, or 8 weeks, does have an increased risk of hemorrhaging, arterial thrombotic events, and hypertension. So we always want to watch out for these things. And we've seen some interesting cases like this one where a patient was treated in one eye for proliferative diabetic retinopathy and they had a response in their fellow eye. We can see from the CAT study that patients that were given Avastin had a decrease in their fellow eye event rate, which could suggest that maybe there's more systemic exposure to Avastin than Lucentis. But overall, I really think it's difficult to make a case for systemic safety. We used to talk about antibody recycling with full-length antibodies, although I think that's now passé. However, when you ask retina specialists, most retina specialists will feel that all of the different treatments are fairly equal. What about for pigment epithelial detachments? These are elevations of the retinal pigment epithelium that cause leakage in the back of the eye. They're notorious for being hard to treat or finicky with how they respond. And we've seen that these pigment epithelial detachments do seem to respond a little bit better to Eylea than they do to Lucentis. Here's from the View 1 and View 2 study. We presented this at the Academy in 2013, where patients given Eylea monthly had a more rapid resolution or more complete resolution of their PED at week 52 than the Lucentis monthly treatment group. That's not saying that we don't see pigment epithelial detachments respond to Lucentis. Here's a patient that had a large pigment epithelial detachment with an active carotid vascular membrane, and after 3 monthly Lucentis injections, it's totally dry. So when we look overall at drug comparison, and I base this purely off of my own kind of concepts, it does look as though the efficacy of Eylea is slightly greater, and we know this, or I feel this way, from switching patients from Lucentis to Eylea. Dosing is a little more beneficial with the Eylea, as we do have that approved Q8-week dosing. Specific lesions like RAP lesions, polypoidal lesions, and pigment epithelial detachments do seem to respond a little bit better to Eylea. As far as safety is concerned, I'm going to knock 1 star off of Eylea because we have had some inflammatory events that kind of occur in clusters, and we've had them ever since the launch of Eylea. It seems like it's less now that we have a pre-filled syringe, but we do still see these inflammatory events, none of which have vascular occlusion as a part of their presentation, but they can be confused with an early endophthalmitis and result in a patient needing a tap and inject and having a month or 2 of decreased vision while their vitreous opacity is clear. And then we can see the big elephant in the room is really the cost difference between these different medications. Let's talk a little bit about our dosing strategies. And there are a variety of different ways that we can dose patients with all of these drugs. There's monthly, there's as needed with monthly follow-up, there's treat and extend, which is the predominant way that I treat patients. And there's the view 1 and 2 approach, and then there's a hybrid approach. So let's look at each of these. So with monthly dosing, as we saw through the Lucentis phase 3 studies, the Anchor and Marina studies, really gives us the best overall outcomes. The disadvantage is patients are getting shots in their eye every single month. And these patients just come in, they get injections, their OCT does improve over the first 3, 4, 5 injections, and then you maintain them with monthly injections. And if a patient comes in saying, I want the best vision, I don't mind getting shots, monthly dosing is probably the way to go. When we started out treating patients with wet macular degeneration, we started using as-needed dosing or PRN dosing. And the advantage of this is really it does decrease the treatment burden. And what we mean by treatment burden is we mean visits to the doctor's office as well as injections. The disadvantage is we undertreat patients. And how we do the PRN dosing is typically we'll do a loading dose where we'll do 3 monthly injections to get the patient as dry as possible. When we see there's no activity, we say, great, everything looks good. I'm going to see you back in a couple months. But a couple months is oftentimes too long and the patient recurs. So what do we do when the patient recurs? We give them a couple more monthly shots. They look good again. And we say, great, I'll see you again in 2 months. What's the definition of insanity? Doing the same thing over and over and expecting a different result. Well, we don't get a different result. Patient comes back and they're leaking again. And so therefore we have to give them a couple more injections. And this goes on. And invariably this causes some vision loss. How can we eliminate that? Well, we know from the CAT study that you can do PRN dosing and have good visual acuity gains, but you have to have monthly visits. And that's what those patients in the CAT study did was they come back for every month visits and we treated them if we saw any fluid. So although there's less treatment burden for the patient as far as injections, there's still a huge burden on that patient just to get to your office and get seen. This way of being treated in the CAT study, the Harbor study, and the Pronto studies all showed to be effective ways of treating patients and maintaining vision. But once again, it's a pretty rigorous follow-up. So most of us have actually taken to this treat and extend dosing. So it provides less treatment burden. There's a little bit more of a mental burden to keep up with how the patients are doing. But a lot of good clinical evidence that this can be just as good as what we see with monthly dosing or monthly follow-ups with PRN dosing. So how do we achieve treat and extend dosing? We do 3 monthly injections or however many monthly injections until the patient is dry. Totally dry on OCT. And then basically once you see they're dry, you give them an injection on that follow-up visit and you say, instead of coming back in a month, I'm going to see you back in 6 weeks. If they come back in 6 weeks and they look good, usually what you do is say, look, I'm going to give you a shot and we'll see you back in 7 or 8 weeks. If they come back in 7 or 8 weeks and they look good, you say, I'm going to give you a shot and I'm going to see you back in 10 weeks. And then if they come back in 10 weeks and they're leaking again, you know you've gone too long, so you back it up to 6 or 7 weeks and you maintain that patient on that 6 to 7 week interval. As long as you see that they're having optimal visual acuity gains with no recurrence of fluid on OCT and no new hemorrhage. The final way of doing dosing is a view 1 and 2 dosing strategy, which is the 2Q8 dosing strategy for aflibercept. And that basically is you use aflibercept and you give 3 monthly doses, and then you go right out to the 8-week dosing. Now, you will see patients, and they did see patients in the View 1 and View 2 study who had active leakage when you extend these patients out to Q8-week dosing. So most retina specialists use the treat and extend method, and this is older PAT survey results, but I'd say now we're upwards of 85% of doctors use treat and extend as their primary therapy. And most doctors use OCT and fluid on OCT more than anything else as the definition of treatment failure. And it's really interesting how we assess these patients. And what we determine as being our overall success, which is preservation and improvement in vision, but our smaller battles are really won on the battlefield of OCT, where we see patients that are maintaining dry retinas. So we're looking at future therapies. One future therapy, which is a combination therapy that failed, is one called Fovista. And this was looking at a pigment epithelial-derived growth factor, and there was some thought that you could combine this. The phase 2 study looked good. The phase 3 study, once again, failed. So there's a graveyard of failed therapies that have tried to enhance anti-VEGF therapy or supplement anti-VEGF therapy or replace anti-VEGF therapy. I don't think anti-VEGF therapy is going anywhere anytime soon. So let's talk about diabetic retinopathy and diabetic macular edema. And first, we'll talk about diabetic macular edema. It's the leading cause of moderate vision loss in diabetic patients, and it can occur in up to 30% of diabetics at 20 years. We have a variety of studies to show when to treat these patients with laser, including the ETDRS study and the DRCR Protocol I study. When we look at these patients with diabetes, we know that there's a certain diabetes belt in the south and southeast that just really has impacted people and patients, particularly in my area in eastern Kentucky, tremendously. Diabetic macular edema occurs in about 10%, about 13% of patients with diabetic retinopathy. 50% of diabetic patients don't receive the recommended eye care that they should, and 50% of patients with vision-threatening diabetic macular edema have not had timely follow-up visits. If we look at these patients that are diabetic over the age of 40, we can see that a significant portion have retinopathy and are not aware that they have any eye disease. And those that with vision-threatening retinopathy, an equal amount are unaware that they have no eye disease. They are unaware of their eye disease, and half of those patients don't have routine eye examinations. Now, diabetes can cause a variety of different comorbidities. So you can see not only do we have to deal with retina problems in these patients, but we have to deal with their kidneys, their nerves, their risk of heart disease and stroke goes up. And so it can be a real burden on patients. How does VEGF affect the eye in diabetics? Well, what we get is we get this chronic elevated blood sugar, and this elevated blood sugar causes damage to the microvasculature, the retinal capillaries. Those capillaries can stop allowing blood to flow as properly as it should. You get ischemia that causes VEGF. That ischemia, VEGF, is elicited from the ischemic dying retina, and it causes breakdown of the blood-retinal barrier. You get leakage that causes macular edema, and then the VEGF can actually cause neovascularization. This is a fairly mild-looking eye on first glance, but when we look at the fluorescein angiogram, we can see extensive areas of lack of blood flow and areas of neovascularization and lots of leakage. And these two things are related. We can see that the non-perfusion results in ischemia, which causes VEGF that drives the neovascularization, and the permeability causing the macular edema. Now, we can treat these patients with grid laser treatment. That's an older school style of treatment, and we can see that we can reduce the chances of vision loss, but we do not oftentimes improve patients' vision. And it's amazing to think that the results here of the diabetic or the ETDRS study that showed a 50% reduction in vision loss in patients treated with grid laser treatment over observed patients were really around since the era of Ronald Reagan, Microsoft Windows 1, and Footloose with Kevin Bacon, Michael Jackson's Thriller. So it was that long ago that we had a treatment for diabetic macular edema until, fast forward to 2008, when we had our first approved therapy for diabetic macular edema with anti-VEGF therapy. Now, we still will use focal laser treatment on occasion. Here's a patient that has a leaking microaneurysm. You can laser that microaneurysm and, I believe, dry up this patient's macular edema, and that's exactly what we did. Steroids can also be used, and steroids have the advantage, actually, of giving a longer durability. We actually compared steroids to focal laser treatment, and it showed that it dried more effectively than focal laser treatment in the DRCR Protocol B as in boy study. But the problem that we saw is that these patients, although the steroids did have a greater drying effect, laser had a better visual acuity improvement. And the reason really was because of the cataract development from the triamcinolone. We also did, interestingly, see an impact in the higher dose of steroids on progression of retinopathy in this study. So we started for the first time ever actually seeing an effect on retinopathy progression with a drug, and we'll get to more of that later. What about a newer steroid for diabetic macular edema, dexamethasone, in a sustained release implant has been released and approved. This is that actual injection. It is a larger needle than what we use for an intravitreal injection. I'm doing this one in the operating room, and we can see here it can just slide in through this trocar into the eye. And this is the steroid implant. We're just very gently depositing this steroid implant into the vitreous here. And you can see how nicely it just slides out. These can shoot out if you push into the wrong area of the depressor. But this can be a very effective therapy. And we know from the Mead study, which looked at dexamethasone implant compared to sham, that over 3 years, patients received 4 to 4.5 injections, and on average, patients had about 20% of patients gain 3 lines or more vision. This is a patient that initially I thought would do well with steroids. We gave them an intravitreal triamcinolone injection followed by focal laser treatment, and this is how they look 4 months after the steroids and laser. I would expect that this patient's edema is going to recur, however, as the steroids do wear off. That being said, to get 4 or 5 months out of an intravitreal steroid injection is pretty impressive. But the most impressive therapy as far as visual acuity gains really comes from anti-VEGF therapy. And we saw this in the DRCR protocol I study that compared ranibizumab to focal laser treatment to anti-VEGF therapy. And what we can see is that basically the patients treated with ranibizumab actually had the greatest gains in visual acuity. Here we can see at year 1, patients gained almost 2 lines of visual acuity compared to the laser treatment group and the triamcinolone plus laser treatment group that struggled to gain 1 line of visual acuity improvement. At year 2, we can see continued improvement in the patients treated with ranibizumab in either prompt laser or deferred laser compared to the triamcinolone and prompt laser treatment group. Most of these patients in the triamcinolone and prompt laser treatment group actually had a loss or went back to baseline on their vision because of the development of cataract. Lucentis was approved for diabetic macular edema based off the RIDE and RISE studies, and what we saw is over 2 lines of visual acuity improvement, 40% of patients gaining 3 lines or more in vision. This is an example of a patient that was treated in the RIDE or with Lucentis for diabetic macular edema. Here's this patient afterwards. We see this profound effect on not just the macular leakage, but the leakage globally. Here's a patient that came in with so much edema that we couldn't even tell that they'd had previous focal laser treatment. And we can see that just after an injection of anti-VEGF therapy, everything calms down. And now we can see actually the patients had previous focal laser treatment. Here's another great example of a patient that's had previous, that came in with proliferative diabetic retinopathy and a premacular hemorrhage, and with anti-VEGF therapy and PRP laser treatment, we're able to calm things down and keep this patient seeing. Variety of questions about DME, some of which have been answered. We have retinal venous occlusive disease, BRVOs and CRVOs. BRVO stands for branch retinal vein occlusion, CRVO for central retinal vein occlusion. Branch retinal vein occlusion occurs where an artery crosses over a vein, and as you get older with high blood pressure, the arterial wall gets thicker and compresses that vein and can cause turbulent blood flow, which can cause blockage. And so blood and fluid cannot flow out through the vein, and it can cause damage to the retinal vasculature, ischemia to the retina, and you can get this extensive leakage picture. Here's the pathogenesis. It's a combination of anatomy, once again, that artery over a vein, hypertension causing the intimal hyperplasia of the artery that compresses the vein. You get turbulent blood flow, endothelial swelling, and that results in thrombosis, which causes ischemia and edema. The ischemia then causes more edema, and you can see it's a downward spiral. What's so interesting is you can have a major branch vein occlusion that occupies an entire quadrant, or a hemiretinal vein occlusion that can occupy the entire half of the retina, or a tiny little macular branch vein occlusion. And when we study these things, we lump them together. And that's always made no sense to me why we would lump something that's so specific, like a macular BRVO, with less extensive ischemia with something that's a major BRVO. And we should probably separate these things in clinical studies. We can study them together. It's just separate them out when we look at overall outcomes. A variety of different treatments have been approved over time and tried over time. I mean, we've tried a variety of things before anti-VEGF therapy, including crazy things like sticking a MVR blade in the optic nerve to try and alleviate CRVOs. But really, anti-VEGF therapy has been the mainstay of treatment since the Bravo and Cruz studies. We can do laser therapy for branch vein occlusions, and we know this from the branch vein occlusion study, where we can see that we have patients less likely to end up legally blind if they get focal laser treatment than if they get observation, and more likely to gain some vision with focal laser treatment or grid laser treatment than if we just observe them. We have the SCORE study looking at steroid therapy, and that compared triamcinolone 1 milligram and 4 milligrams to grid laser treatment. And what we could see from that study is that all the patients did about equally well. And this is really why we've moved more towards using a lower dose, or the 1 milligram dose of steroids, when we use intravitreal triamcinolone. We also have the Ozurdex injection approved for branch vein occlusion, and we can see here that the Ozurdex was approved, and basically the patients, about a third of them, would gain 3 lines or more of visual acuity, typically around 60 days. They did really kind of handicap the Ozurdex by not giving it more often in the study. Now, when we look at anti-VEGF therapy, and I apologize for how quickly that flipped through there, but we can see that the average patient gains over 3 lines of visual acuity. We have 60% of patients gaining 3 or more lines of vision, compared to a third of patients treated with sham, which is focal laser treatment. So when we compare triamcinolone to Ozurdex to Lucentis in the phase 3 studies for branch vein occlusion, we can see that 60% of patients gaining 3 or more lines of vision really dwarfs the 30% of patients that we see with Ozurdex and the 26 to 30% of patients that we see with triamcinolone or laser. This is what we see when we treat a patient with anti-VEGF therapy: a rapid clearing of the hemorrhages, which is frankly remarkable, and an improvement in the edema on OCT testing. And we can see this not only in those macular vein occlusions, but also in these major branch vein occlusions. So we can see here where the occlusion is and the extensive leakage. Here's after a single anti-VEGF injection. And you can see there's an extensive amount of ischemia that we can now see that we have these vast vessels stabilized. Now, anti-VEGF is not a panacea. Here we can see a patient that's received monthly Avastin times 3. They still have fluid, albeit better. 3 more Avastin injections, and still an extensive amount of leakage. So where do we go next? And for me, I'd probably try a different anti-VEGF therapy. A cousin or nephew to the branch vein occlusion is a centroretinal vein occlusion. These, I guess, probably more like siblings. This type of occlusion actually occurs further back in the optic nerve head. And so it's basically where the artery and the vein share a common adventitial sheath. And once again, that artery, as you have hypertension and aging, compresses the vein, causes turbulent blood flow, and causes an occlusion. And we can have a variety of different things that can look like a CRVO, such as this patient with polypoidal, this patient that has ischemic optic neuropathy, this patient who has a leukemia. The big key on this patient is they don't have venous engorgement, and this patient who has multiple myeloma. Once again, no venous engorgement, no disc edema in this patient. That's the tip-off that this patient did not have a CRVO, but rather had a multiple myeloma. And you can actually see some of these look like Roth spots with white central hemorrhages. So we used to classify centroretinal vein occlusions based on their perfusion status as either ischemic or perfused. The perfused CRVOs could convert over to ischemic ones, and that was devastating. But as one would imagine, the perfused CRVOs are better than the ischemic CRVOs as far as your visual acuity and whatnot, and you just have to, in the old days, keep your fingers crossed that the patient didn't become ischemic. If they did become ischemic, some of the things we had to worry about were things like neovascular glaucoma, because you now have this ischemic, starving retina in the back of the eye. The entire retina is starving, lack of blood flow, and you have this high VEGF state, the highest of any disease state. And this promotes the growth of abnormal blood vessels in the front of the eye. And if those blood vessels grow into the drainage angle, it can occlude the drainage angle and cause glaucoma. We know from the CVOS study that if the initial visual acuity oftentimes is predictive, although not always, of their final visual acuity. And so those patients that presented with good visual acuity most often ended up with good visual acuity. If you were 20/40 or better, 65% chance you would end up 20/40 or better. However, if you presented with 2200 or worse vision, you had a very good chance of ending up 2200 or worse. Here's a variety of CRVOs that I've seen in my practice. Here's a milder CRVO. Believe it or not, this patient, after 12 years, still receives injections of anti-VEGF therapy every 4 to 6 weeks. Here's a more ischemic CRVO, and we can see it on their fluorescein angiogram. More capillary non-perfusion, and this is probably the most ischemic CRVO I've ever seen in a younger gentleman, actually. And what we can see is that he has this almost this phlebitic, inflammatory look to his retinal vessels. And you can see the early non-perfusion peripherally here. We can see the rates of ischemia. As we have more and more ischemia, we get more and more macular edema and decreased vision. If we look at our patient who presented with very poor visual acuity, that most ischemic CRVO patient, after 6 monthly Avastin injections, we finally get an idea of just how horribly perfused this poor fellow is. His vision's 2400, but that's a lot of non-perfused retina. As an aside, this patient moved away for several years and returned back about a year and a half after I'd last seen him. And he'd been following up with a retina specialist in his area that he had moved to, but he had developed neovascular glaucoma. And we had plans to do PRP laser treatment on him, but he had moved away. He was observed elsewhere. And this ischemic retina, we basically had just delayed the presentation of his neovascular glaucoma. So we did extensive PRP laser treatment to this dead, dying retina in the ischemic areas. One of the things we have to deal with CRVO is this macular edema. And here we can see the visualization of macular edema. When we look at the CVOS study, or the SCORE study, we looked at observation, which focal laser treatment's not effective for edema from central retinal vein occlusion, compared to 1 milligrams and 4 milligrams of steroids. And we can see that for 3 lines or more gained, that the steroid groups actually worked. We see this as well with the Ozurdex or dexamethasone injection. But the real gold standard comes from anti-VEGF therapy. And it's really the CRUISE study that showed average patient had 3 lines of visual acuity gained. So when we compare these different studies, what we can see is that whereas with steroids getting 25 to a third of patients with 3 lines gained, we're getting about 50% of patients with 3 lines of visual acuity gain with anti-VEGF therapy. And with aflibercept, we're seeing upwards of 60% of patients with 3 lines of visual acuity gain. This is a patient that we treated with Avastin. We can see a rapid improvement in their edema and OCT and 20/50 vision. Here's this patient's intraretinal hemorrhages clearing as they receive treatment, and we can see that they almost look completely normal. Once again, I mentioned anti-VEGF therapy with Eylea, and we can see 56 to 60% of patients with 3 lines of visual acuity gained. These patients do outstandingly well, and I do feel that this higher VEGF state is one that a therapy like aflibercept or Eylea may have a preferential benefit for, in that it has a higher binding affinity and a greater concentration and a longer half-life. So this may be why we see these unprecedented visual acuity gains. When we see patients who present earlier with their CRVO, we know that we have a better chance of recovering vision. So really when we lose vision permanently, it's more often because these patients have gone longer. One would think that the non-perfused CRVOs would not respond as well, and although they do present with worse visual acuity, we can still see that those patients actually can have significant visual acuity gains with intravitreal aflibercept injections, similar to what we have with the perfused CRVOs. So when we compare our anti-VEGF therapy, we can see that once again, Lucentis, Eylea, and even Avastin work very, very well for edema secondary to central retinal vein occlusions. Do we know which is more effective? We don't really have a study comparing all three. There might be a dosing advantage with Eylea. I think there still is a role for steroids in patients with CRVOs that need extended dosing or fail to get completely dry. And there probably is a role for laser, mostly PRP laser treatment in the CRVOs and very ischemic quadrantic BRVOs. And this is also an area where sustained release devices may be important. So once again, in conclusion, all three of these diagnoses, wet AMD, diabetic macular edema, and retinal vein occlusions, all benefit from early therapy. Anti-VEGF therapy is really the standard of care in most cases. There's not much of a role for adjunctive therapies, with the exception of steroids, perhaps, in diabetic macular edema and RVO. Our dosing strategies, particularly treat and extend right now, are absolutely critical. And we need to think about the systemic implications of not only our therapies, but of the patient's disease state, specifically for diabetic macular edema and what it means as far as those patients and their diabetic disease state, and for RVO patients, their hypertension and other comorbidities. I want to thank you for watching this and listening to this, and hopefully it was helpful.